Welcome everybody to Milford Regional Medical Center. I'm Donna Boynton. I am the Public Relations and Community Benefits Coordinator here at Milford Regional. Tonight we are pleased to have Dr. Peter Orio, who is presenting our first community lecture this spring. He'll be discussing prostate cancer. Dr. Orio is a graduate of the University of New England College of Osteopathic Medicine. He continued his training with an internship at Brooke Army Medical Center in San Antonio, Texas, and a residency in radiation oncology at the University of Washington Medical Center in Seattle, Washington. Dr. Orio is an assistant professor of radiation oncology at Harvard Medical School and is nationally known for his expertise in prostate brachytherapy. Dr. Orio sees patients here at Milford Regional Medical Center across the street at the Dana-Farber Brigham and Women's Cancer Center. Tonight's program is being videotaped for those who couldn't join us, and in case you want to review it later. Following this evening's presentation, Dr. Orio will answer questions, and he'll also be available to talk to you one-on-one should you not feel comfortable asking a question. So, Dr. Orio.
Well, thank you. Good evening. As Donna said, I'm Peter Orio. I practice radiation oncology in the Dana-Farber Brigham Women's Cancer Center system. We have many of these satellite facilities, and I do see patients one day a week over at the Milford Center right across the street. Today, what I want to try to do is keep this pretty informal. If you have questions as I'm going along, yell them out, raise your hand. I'll repeat them so everyone can hear them. But let's just use this time together to go through some data and to try to figure out, what's the best treatment strategies, because prostate cancer used to be something that we thought was pretty easy, and it's become very, very complicated. So today I'd like to talk about a little bit of what is the prostate, since we're talking about prostate cancer. What does the prostate do? How am I diagnosed? What stage of disease do I have? And what are my best treatments based upon my stage of disease? Because really, we need to be careful because our first shot of cure is our best shot. So what is the prostate? The prostate is an exocrine gland. Basically, it makes a solution or a fluid. It's about 25–30% of the ejaculate when a man orgasms. It keeps the sperm in a liquid phase, so it makes it easier for men to father children. So it's a reproductive organ, basically. We need it to have kids. But really, the prostate can be designed to be a ticking time bomb. It causes a lot of worry, grief, confusion, and controversy. There's some suggestion that if we live long enough, every man will get prostate cancer. At this point, 1 in 7 are diagnosed in their lifetime. But if we live into our hundreds, if we keep going through, there's a high probability that a lot of folks will get prostate cancer. So what do we do to prevent problems in prostate cancer? How do we diagnose it at an early stage so we have a lot of treatments and we can make sure that we can get after it and we can make sure that we can cure it? Well, prostate cancer screening. Anybody greater than 50 in this room who's a male is probably very familiar with the digital rectal examination, a fancy way of saying the doctor touches you with a sun don't shine and touches the prostate to see if they can feel any cancer. It's really done now in the PSA era by itself. It's not very predictive. Basically, you can feel things 25–35% of the time that actually mean anything, but it's relatively inexpensive and it's relatively non-invasive. Of course, that's really in the eye of the beholder. I hit a magic age, and my primary care doc turns out to be a classmate from medical school as a female and said, "It's time for your prostate exam." Like, you've got to be kidding me. But so I can relate now, I guess. So what are we feeling for? We're basically trying to feel for cancer. Can we feel any nodules within the prostate? And if so, where in the prostate? Just on one side, both sides? Is the prostate cancer going past the prostate itself? This all portends prognosis, and it helps us predict stage. It helps us determine what are our best treatment options. So it's part of the clinical picture and a very important one at that. If I can feel something, that means things have been growing for a long time, and we need to intensify our treatments. PSA, though, is really the way we've been screening men since the late 1990s. There's a lot of controversy with PSA. You can't open up a newspaper or a magazine and sort of, understand that people are saying, well, don't get your PSA tested. There's no need. It's not sensitive. It's a waste of time. And the problem is there's no PSA that you can possibly have that assures you don't have prostate cancer. We use 4 as a cutoff because we know if your PSA is above 4, there's about a 30 to 35% chance that a biopsy, they're going to find cancer cells under the microscope. But you can have a PSA of 2 or PSA of 1 and still have prostate cancer. The value of the test, though, is it's simple. It's objective. A number comes back to us, so we don't have any subjectivity. Did I feel something? Did I not feel something? I've got a number in front of me. It's relatively inexpensive. and it's not invasive, it's a blood test. PSA no doubt has decreased the detection of prostate cancer at an early stage, which is very curable, but it also has led to overtreatment of many cancers that just don't need treatment. And I think that's really the controversy. It's not that we should find out if a man has prostate cancer, because some men have high-risk cancer that needs to be treated or it's going to become problematic. It's that a physician should have a responsibility not to treat the ones that aren't going to lead to a man's death. They can live with a prostate cancer. We're going to go through this. So things have happened. In 2012, to lead to the controversy, the U.S. task force basically said, hey, prostate cancer screening is not needed. We don't need to do it for men. Primary care docs stopped doing it. We're going to give it a grade D recommendation. We all went to medical school. We don't like Ds. Ds are scary. You know, that's not good. So if someone says it's a D, that's a failing grade, so we should stop doing it. Well, we did. And we've noticed that when you look in that time interval, men were not getting screened, or there was a decrease in screening. We were diagnosing less prostate cancers. In 2014, about 233,000. It decreased to about 167,000. Doesn't mean that prostate cancers weren't there. We just weren't detecting them. When you look at the death rates on the screen, they stayed relatively the same. So people still die of high-risk cancer. So maybe we should be detecting it. And so the task force basically said, okay, our bad. We're basing this recommendation on bad information, and we're going to give you a C. Well, C is better than D. It's not great, hoping for an A, but it's a C. And I think this really helps us now have conversations with patients to say, listen, PSAs aren't perfect, but it's what we have. We'll have a conversation. If your PSA is elevated, we'll have a conversation whether or not you need a biopsy. And so there's different societies, the AUA, American Cancer Society, but basically is saying we should be screening, we should be having conversations. It can't be just for everybody, but we should be talking, especially if you're in that age range where we can do something, because it could affect your ability to live with the cancer between 55 and 69. How do we diagnose prostate cancer? Well, biopsies. So I know I see some of my patients in this room, so I know there's a few of us, or a few people have been through biopsies in this room, and I'm sure there's others. They do it with an ultrasound. Ultrasound goes in the rectum, needles go into the prostate. It's blind. They take 12 samples, two from the top, bottom, and middle, from the right and the left, to equal 12. But we're not targeting anything. We're just biopsying. So big prostate, 12 biopsies. Small prostate, 12 biopsies. So there's a probability that you can miss. We know we miss 35% of the time, because we know if we go to prostatectomy, if we haven't taken out and you look under the microscope, you can find some other cancers which we didn't know about on biopsy. So we don't always know what we're treating. And so maybe it's time to personalize our approach. And what's coming into vogue, and it's something that now Milford Regional Medical Center is doing as well, we've been doing this at the Brigham for an awful long time, is multi-parametric MRI scans. It's basically an MRI that allows us to look inside the prostate with different imaging, different ways to see. So we get these pretty pictures, and we have an understanding whether or not there's cancer within the prostate. And so now we can be a little more precise in our biopsy, because we're not doing it blindly. We can actually target it using an MRI. The radiologist developed a system. It's called the PIRAD system, between 1 and 5. If they give me a score of 1 on a lesion, basically, I'm not too worried about it. Probably benign, nothing to biopsy, 2% chance of it being cancer. If I see a PIRAD 5, there's about a 90% chance that that lesion could be cancer, and that deserves biopsy. And there's actually a study, and we have to do all studies because we need insurance companies to pay for what we do. And basically 500 men were randomized to regular biopsies or MR-directed biopsies. And basically what's happening is we're starting to diagnose less clinically insignificant cancer, stuff that we don't need to treat. There's no sense letting a man worry about something that doesn't need to be treated, because once it's done and you know about it, it's in your mind forever. We're finding higher risk cancers and basically significant cancers. So essentially we're actually hitting what we mean to hit, and we're getting what we need to know. So once we have a biopsy, we have to look at the Gleason score. This is the pathology. So the pathologist is looking under the microscope and deciding a grade between 1 and 5 of how aggressive the cancer is. 1's not aggressive, 5 is very aggressive. What they do is they look at the pathology slide and they say, well, I see mostly this, and they assign a number between 1 and 5. And then I see, the second most I see is this. So with the Gleason score, you can get a score between 2 and 10. The truth of the matter is no one gets 2, 3s, 4s, and 5 in this country. 6, 3 plus 3 is low risk. 7 intermediate, 8, 9, and 10 high. But this needs to be further refined. It's confusing. So someone comes and sees me and says, well, I have a Gleason score of 7 cancer. The first question I need to know is it a 3 plus 4, meaning most of the cancer was sort of benign around the mill, or is it mostly 4, which is problematic? So in 2016, the World Health Organization changed the grading systems. And this is actually something that it really hasn't permeated to the general public yet. We're using this in the academic centers, and we still report this with Gleason score, but we're trying to have 5 risk categories, 1 through 5. Make it simple. 1, low risk, don't do anything about it. 5, we better really intensify our treatment. And so it hopefully will make it easier for physicians to talk with their patients, because now, instead of all the nuance and confusion, we're basically boiling it down to 1 through 5. And it's been validated in prostatectomy specimens and as radiation specimens. So grade 1, basically what used to be Gleason score 3 plus 2 equals 6, low risk cancer is WHO grade 1 or group 1. And you can see that if you have a radical prostatectomy or surgery, or radiation, you're going to do equally as well. As you have more aggressive cancers, your ability of having progression-free survival, meaning the cancer doesn't come back, gets lower. So it means we need to treat more aggressively. And you can see with the high-risk cancers in the radiation realms, there's about a 50% chance of having freedom from progression with radiation, but it dips down to about 15% in the surgical arm. So something to pay attention to. And we'll go through more of that as we go through this presentation. So what's your clinical stage? Well, in the past, we used to diagnose everything, what kind of risk category stuff, by PSA. How high is your PSA? Clinical exam, what can the doctor feel? And biopsy, what did they see under the microscope? How aggressive was it? But we're trying to further refine that. I'll show you some research from my group where we're looking at how many cores did you have positive? Did you have 1 out of those 12 cores positive for cancer, or did you have 7? There's going to be different prognostic factors with that. How much of that core, which was positive, had cancer? Was it 5%, just a little teeny bit in that core? Or was it fully 100% involved? That's actually prognostic. And of course, we look at the MRI. Is the cancer going past the prostate? Is it going in the seminal vesicles? Is it going up into the lymph nodes? That helps us intensify treatment as well. So we're really looking at the whole picture. In the past, we used to just pigeonhole things. Those are my versions of pigeons. Not very good, but they're coming to land. You have low, intermediate, and high-risk cancer. That's the way it was. You fell into one of those 3 categories, and we treated you accordingly. But we realized prostate cancer is a spectrum of disease. It's not low, intermediate, high. It's so much more than that. It can be clinically insignificant to we better throw the kitchen sink at you to make sure we cure you. So research is coming out, and this is something that comes from our group, one of our residents who wrote this up. But looking at 10,000 patients, and we're looking at these big cancer databases, and patients who we thought to be low risk, we went and we looked, well, whatever happened to them when they went to prostatectomy? How many of those patients were upstaged or upgraded? And what it came down to is the more cores you had positive, so if I did a 12-core biopsy and I had 6 or more, greater than 50%, my probability of being upgraded to Gleason score 7, 8, 9, or 10, or clinically significant disease, rose. Or, same thing was upstaging, meaning that when we looked under the microscope, the cancer was going past the prostate. And we thought these folks were low risk, and we're going to treat them low risk, and we're going to say, basically, let's not do much about this except for watch it. And it also correlates with PSA. So if you start to have a higher PSA, and you have more cores positive, it's a higher probability of those low-risk cancers being upgraded. So we need to pay attention to all of this as we start to explore active surveillance or watchful waiting strategies with our patients. And here's another one I just want to put out there, because we know the median age of diagnosis is 66 for prostate cancer. So about 66 is when we see the slopes go up for men being diagnosed with prostate cancer. We were looking basically at folks who had low-risk cancer but greater than 50% cores. We're saying, well, maybe we should stop calling these people low risk. Maybe they're high risk. But I think the thing that's really telling on this slide is the blue on the bottom. That's low risk cancer at less than 50% cores positive. So the chance of being upgraded pathologically is pretty low. That's more than 50%. But look here. As we get older, we're harboring more clinically significant disease. So when we see patients, we're actually looking at age. Because the older we get, even though we have a low risk biopsy, well, there's now a 30% chance that there's actually higher risk disease within the prostate. So this all comes in the clinical decision-making that you have with your physician. So our 3 little birds' nests have really turned into a whole pigeon coop. We realize that prostate cancer is a spectrum of disease. So it's no longer low, intermediate, and high. Now it's very low, low, favorable, intermediate, intermediate, unfavorable, intermediate, very high, locally advanced, and oligometastatic. And I forgot there's a high in there too. So you can see how it's becoming a little more complicated, but this is important because, again, first chance of cure is our best chance of cure. And so this is the Dana-Farber Brigham cancer risk definitions, and this will be online for everyone to see, but basically we stratify things down from low to very high-risk disease based upon PSA, clinical score, Gleason score, how many cores are positive, findings on MRI. This is important because when you're talking with your physicians, they need to be aware that all of this stuff is out there, and all of this stuff really needs to be incorporated in decision-making because we need to have an appreciation of what's the probability of the cancer going past the prostate. If it's gone past the prostate, you don't want a prostatectomy. It's as simple as that. So we need to really be cognizant of all of this. So what are our treatment options? Well, there are many competing treatment options, and there's bias with everybody. Now, I'm known and I do a lot of stuff. I'm the president of the American Brachytherapy Society, so I love putting seeds in the prostate. One of my things that I do, but I also love using radiation beam. I'm a radiation oncologist. But you meet surgeons who want to take it out. They're surgeons that were trained to do so. So I think the take home here is there are many treatment options, and it really behooves you to talk to as many people as possible. So the support groups coming to meetings like this, but never just take the advice of one physician. If your surgeon says, "We've got to take this out next week or you're going to die," we'll say, well, that's not true. Never seen that happen. Let me go talk with a radiation oncologist. Heck, let me go talk with a medical oncologist because they don't have any skin in the game. And you start to build your network of people because knowledge is power. You need to know what you're dealing with, and we all have biases. We try not to. We try to be educators as physicians, but we also have experience, and we don't want that to come through. We're basically here to try to help educate, and we do make recommendations, but it really is, unfortunately, patients, we have to all be our own advocates. We're all patients at some point. So I'm going to talk about organ-confined disease. And I'm going to talk really about active surveillance, prostatectomy, external beam radiation therapy, and prostate brachytherapy. I'm not going to talk about HIFU or cryotherapy. We don't use it on the Dana-Farber Brigham pathways. We know it exists, but we don't feel it's curative at this point. That might change in time. Our pathways are reviewed every 6 months. But right now it's not ready for prime time. So we're going to just keep the conversation to this. What is active surveillance? Now, a lot of men are diagnosed, as we said, with clinically insignificant cancer. Basically, Gleason Score 6 disease, couple of cores positive, PSA very low. The chances of dying from that are very slim. We can watch it. Doesn't mean we're going to forget about it, but we can watch it. We can do a biopsy in another year to make sure we didn't miss anything on the first biopsy. We can do an MRI to make sure there wasn't anything else in the prostate that needs attention. We're going to do PSAs every 3 to 6 months. We're going to do examinations. If anything changes, we're going to flip into evaluation mode, get more tissue, and make sure we didn't miss anything, and offer treatments at that point. You can basically stave off any potential side effects of treatment. We're mortal creatures, unfortunately. Our goal is never to die of prostate cancer because that's something that's very curable. But there's oftentimes we can live and die with prostate cancer, but die of something else, and we can avoid the treatments of cancer, prostate cancer. But of course, we can miss things, and that's the truth. We can let the cancer progress, metastasize. Things may become kind of out of whack. We might have less ability to cure if we let things go too much. As a psychological, I have cancer, I'm not doing anything about it. We know folks who are good for active surveillance fall off active surveillance because they don't want to go through any more biopsies, or they're sick of wondering when's the other shoe going to drop. We appreciate this, and that's why we have conversations. So we don't say, well, you have this grade of cancer, we don't treat you. It's a conversation. We want to make sure that's always put on the table versus you have cancer, we must treat, because I think that's irresponsible as physicians. So prostatectomy, I'm sure a bunch of folks in this room have had this. That's when they go in and they surgically remove the prostate. 95% of the prostates done in this country now are being used with the Da Vinci robot. So the surgeon's in the corner of the room, the robot's in the body, and it's kind of doing its thing, which is wonderful. Less blood loss, less hospital stays, maybe a little less incontinence possibly. But basically, the bladder empties into the urethra. So the bladder empties into a tube that we pee through. Goes from the bladder, the urethra goes smack dab through the prostate out through the penis. Design flaw. Because when we have to take it out, we have to cut the prostate above, the prostate below, then pull up the urethra and sew it all back together. So sometimes there's some issues with continence. They try to spare the nerves, but if we don't spare the nerves well, there's chances of erectile dysfunction. External beam radiation therapy, so that's my kind of wheelhouse. That's when we use volumetric treatments. These machines spin around you in 360-degree arcs. We're treating the prostate, the seminal vesicles. Sometimes the fields include pelvic lymph nodes because of the high risk of spread past the prostate. And there are times when the nodes are positive, where the lymph nodes caught cancer, it's caught up, but we can use special dosing strategies to give more radiation, because the more radiation we give to cancer, the higher probability of cure and control. And then there's prostate brachytherapy. Now we can do this with low dose rate or high dose rate. We do both. For the sake of this talk, we're going to show you some of the low dose rate that we do here at Milford. We put radiation seeds directly into the prostate. So we put the radiation where the cancer is. We can give a lot of radiation because the fall off of the radiation seeds is such that you can prevent the radiation from going into the rectum, urethra, or bladder. So you have a tighter control, we can give a whole lot more. It's surgical, do go to the OR, you will be asleep for about an hour, it takes about an hour to do. Intraoperatively planned, but we figure out how many seeds to get into the prostate. And then when you look at the isodoses, these are just fancy colors of, what did we do, how much dose do we give? We can spare the urethra, the tube we pee through. We can also spare the rectum. We can give a lot of dose to the areas of concern. In fact, we'll go through some of that as we go. So let's talk a little bit about treatment options by risk group. And so we put together very low, and favorable intermediate risk. I put these together because when you look at the pathways, they're very similar. Now, I don't expect anyone to read this, except the take home is that everything at the Dana-Farber Brigham is on a pathway. This is important. We've got about 45 radiation oncologists that work through our system. There are 5, 6 individuals who just treat prostate cancer. I'm one of them. But this keeps us all on the same page. We're reviewing the literature on a 6-month basis, making sure that we have the most up-to-date recommendations possible. We use these pathways because no matter where you impact the cancer center, from going into town or going over to Milford or Weymouth, South Shore, heck, you can go to Bermuda and China now because we have cancer centers there as well, you're going to get the same standard of care. Very low risk. And low risk, basically, our primary treatment strategy is active surveillance. We understand you have cancer, we'll watch it, we'll treat it when it becomes clinically necessary, but we're not going to rush into it today. If you want radiation, our number one treatment choice is prostate brachytherapy. I'm part of the group, maybe I've influenced this a little bit, maybe it's biases, or maybe it's because we really do look at the literature, and it's really because we do look at the literature. And we have to understand that we have to break things down in the intermediate risk setting from favorable to unfavorable, because we understand what favorable, that 3+4, or that now WHO grade 2, and that's really hasn't permeated too much into the lexicon of the communities yet, but we know that favorable intermediate risk, the 3+4s, do just as well as the 3+3s, or low risk, so we can treat accordingly. We know the unfavorables don't treat as well. So these spreads you see, chances of distant metastases, with unfavorable risk prostate cancer is a higher chance of having distant metastases. Cancer goes from the prostate, finds its way someplace else, typically in the bone. Bad place to go because it's painful, it's uncomfortable. So favorable risk. Again, life expectancy less than 10 years, we're just going to kind of pay attention, watch. We'll get after it if we need to, but we don't have to treat it. If your life expectancy is greater than 10 years, if surgery could be an option if it's organ confined. But if we're going to go and do radiation, brachytherapy is our preferred option if a patient qualifies. But not everyone qualifies. We're going to get through on that. Otherwise, external beam radiation therapy, the radiation from the outside in, works just as well. Peter Grimm, he was a mentor of mine. Donna mentioned I trained at Seattle, Washington. Seattle, Washington is where prostate brachytherapy kind of epicentered in this country 30 years ago by the Seminal technique. First implant was done in 1986 by Dr. Grimm, Dr. Sylvester, and Dr. Blaskow. And Dr. Blaskow was sort of the senior leader of the group. Dr. Grimm was kind of the person who really pushed this forward. Peter realized that it's very confusing when men are trying to go through their treatment options. Should I have surgery? Should I have external beam radiation? Should I have brachytherapy? Should I have high dose rate, low dose rate, high flu, the whole thing? He took it upon himself to put this prostate cancer results study group together. He passed away 2 years ago, unfortunately. I lost my mentor, but I am helping run the society now, this study group, where we look at all the literature. And we try to make graphs to help individuals make treatment decisions. This is before we had randomized data, which we do, and I'll show you, because you want flip of a coin data. One guy gets this, one guy gets that, compare outcomes and see how they've done. But this is what we're looking at. And you can see in the low risk settings, you can do really anything and you gotta do well. The prostate brachytherapy works pretty well too. So a couple of years ago, for the first time, they did this in England. It's the only place you're gonna pull this off. they actually had men randomized, meaning that they came in for treatment. And they said, do you want to participate in a study? And they said, yes, I'll participate in a study. Okay, I'm going to flip this three-sided coin. And we're going to either watch you and not do anything, we're going to give you external beam radiation therapy, or we're going to do prostatectomy. Because I know a lot of you in this room have talked to surgeons before and said, well, the only way to cure this is if we do a prostatectomy. And the radiation oncologists were going, well, I don't think that's true, but we don't have any data, and we're very data-driven. Well, it turns out that there was no difference in overall survival for the low and the favorable and intermediate risk patients. So you could watch it, you could do surgery, you could have external radiation, you'd live just as long. You're going to die of something else. Overall survival is 99%, essentially. The folks in active surveillance, they did have double the rates of distant metastasis, and 70% of them then eventually have to have treatment, but they were salvaged so they didn't die. Now, there's a little bit of nuance there because you don't want salvage and have to put out fires to stay alive. You'd prefer just to go on living happily without any troubles, one treatment and go. But overall survival is the same. Prostate cancer-specific mortality, identical between the three groups. Freedom for disease progression, identical between radiation and surgery. Obviously, folks in the active monitoring did progress, but they were salvaged. In fact, 53% of patients in the active monitoring group did have to receive treatment within 10 years, but they did, and they did okay. So the take-home message is, although they had to deal with something, they lived just as long. So now you've got some great data for active surveillance, but you also know radiation works just as well as surgery, even though I know people in this room have had conversations which are different. But they did great quality of life stuff. So if you're going to submit yourself to treatment, what are we going to do as physicians? What is the problem? What are the side effects? What are we going to do to alter you? And this study looked at that. And when you look at the urinary toxicity, men did very well with active surveillance, as you would expect, because we didn't do anything, or radiation. The chances of having to wear pads at 6 years was 4% if you had radiation, 6% if you had active surveillance, but it was 17% if you had surgery. What about sexual function? Well, all men took a hit in that arena because the prostate, again, is a sexual organ in the terms that it makes fluid and secretions when we have orgasms, but of the 67% of men who joined the study who could have erections adequate for sexual intercourse, at 6 months, defined as erections firm enough for intercourse, so it was 52% in the active surveillance group, meaning we didn't do anything, so we wouldn't expect much change, but time does go by, and we all know in this room who are men, father time is not kind in that department. 22% of radiation patients had erections, but they were also getting hormonal therapy. That's a way of taking away a guy's testosterone. We do that in the higher risk settings. Back then they were doing it in the intermediate risk settings, but once you take away a guy's testosterone, it's hard to have erections during that period. So flash forward to 6 years later, 30% of patients in the active surveillance arm were having erections adequate for sexual intercourse, 27% in radiation, but only 17% in radical prostatectomy. So when you're choosing your treatment option, I tell my patients all the time, there's no free lunch. There's no way to avoid side effect. What side effects are you most comfortable accepting? Ball function. Well, that's where radiation lost. Now, not by much. These were kind of older techniques using 3D conformal radiation. We really haven't used those techniques in this country. Well, since I was a resident about 15 years ago, we use IMRT, which is much more forgiving. We can really carve out the bowel, but they lost in that realm. We've realized, and we're realizing as we go, that there have to be dose constraints. You can only give the rectum so much radiation dose before you can cause long-term troubles. And folks who've had radiation 20, 30 years ago have some troubles. The new generations with the new technologies, there's less because we're also paying attention to all of this. But there's something that we're doing here in Milford that I just thought I would introduce. It's called SpaceOR. I introduce it because it's advertised on sports radio and Sports Hub, which is interesting. There's only a handful of us who are qualified to put this stuff in. And I'm like, wow, they're advertising to, hundreds of thousands of people, I assume, listen to the sports radio, at least I do in the morning. And what we have now, for patients who we think would benefit from it, I can inject a gel between your prostate and your rectum. I can push your rectum out of the way. So your radiation dose falls into the gel and not into your rectum. So it basically looks like this. It's just an outpatient procedure. The needle goes to the perineum, just a little local anesthetic. I use this a lot during brachytherapy. Put the needle in, I put some saline in, dissect everything out. Local anesthetic, like Novocaine, lidocaine, that's all that is required. and boom, hydrogel goes in. That gel stays intact for 3 months, dissolves by 6 months, and then you pee it out basically. Pretty amazing. So this is going to allow us to give more doses of radiation from the outside in, because the thing that we worried most about was toxicity to the bowels. Well, now we have something that might help counter that. So pretty interesting technologies. And the company did a randomized trial. They did one in Europe and they did one in the United States. And basically what it came down to, at 1 year, there's a 46% less likelihood to experience long-term bowel dysfunction if you have the spacer in place. Now, not everybody needs it. Overkill for a lot of treatment technologies, but it's nice to know it exists. Nowadays, if I go to the OR, I have patients sign a consent saying, I don't know if I'm going to need it, but if I do, it's nice to be able to take it out of the back corner of the room and put it in if we have to. And that's what it looks like on the MRI. And to put things in perspective, when we're doing radiation, we're treating 5 millimeters past the prostate to curative dose. That's 10 millimeters, basically half an inch. And so your radiation doses fall in the gel, not into the rectum. So we kind of lost with the old techniques, but now we can win again if you wish, if we put this in. So what about brachytherapy to surgery? Well, if they could do a flip of a coin between surgery and external beam radiation, surely we could do a flip of a coin side between surgery and brachytherapy. We tried this. They tried this when I was in Seattle, in the early 2000s, and it was a disaster. Most guys came in and said, "Do you think you're going to flip a coin?" No way. I'll pick what I do. They were able to randomize about 34 people. We kicked this study to Canada because the Canadians have kind of cancer centers where they're more centralized in location. So, you have a little more control of what could be done. And most folks said, okay, well, I'll participate in your trial, but I'm choosing what I'm going to have. And the outcome studies haven't been done, overall survival, PSA control, although you're going to expect them to be similar because they were treating low-risk patients. And again, we're just saying that we don't even have to treat low-risk patients. But the toxicity stuff came out, published by Juanita Crook, a wonderful lady out of Canada who's just a guru in prostate cancer. And essentially, brachytherapy had less urinary leakage, which would be expected. We're not changing a man's anatomy. We're not cutting out sphincters. We're not violating the way God made us. There was less the urinary obstructive symptoms, weak stream, the same between prostate brachytherapy and surgery. Now, right after prostate brachytherapy, you're definitely going to have some symptoms, and there's some folks in this room can attest to that. However, long term, it's basically just the same as radical prostatectomy. And sexual outcomes were better, meaning, erections firm enough for sexual intercourse with prostate brachytherapy than with surgery. And of course, some of those patients were randomized, some of them will watch. There's some biases in it, but it's interesting data, and it's the best we have when you try to put surgery to brachytherapy head to head. This is where it gets interesting, because this is where we can really affect change. This is folks in this room right now who fall into these categories, the unfavorable intermediate and the high risk. This is where I can give you information that can really alter how you do. All the other stuff, dealer's choice. You could probably do anything, do just as well. It's just side effects we're talking about. Maybe side effects you don't want, but it's just side effects. We're not really talking too much about cancer control. But this is where those curves separate drastically. So this is the important stuff of this presentation. We know that the higher the risk group you have, we were talking about those pigeonholes at the beginning, low, intermediate, high. Now we further refine them. There's a chance that cancer goes past the prostate, the higher the risk group you have. If the cancer is past your prostate and you don't treat past the prostate, we didn't treat you. We left cancer behind. If we leave cancer behind, cancer is going to grow. Cancer grows, we have to give you salvage therapy. Salvage is never a good word, and we use that for the kind of therapies that we have to employ. So, there's been a great study by Brian Davis out of Mayo. He looked at 376 radical prostatectomy specimens. So basically looked, if a guy did have extraprostatic extension, how far past the prostate did it go? Well, typically it went no more than 1 millimeter past. Now, 1 millimeter is not much. It's very little, actually. But if you're just lifting something else and you leave something behind, it's there. With radiation, we're treating with 3 to 5 millimeter margins. I call them kill zones. I spent a lot of time in the military. I mean, that's not the right thing to say, but basically we're setting up a kill zone around the prostate. And as such, we're going to encompass that 99% of the time. So if the cancer's passed, it's within our treatment fields. So this is a nice talk. I do a lot of talks all over the place, and a lot of times I'm kind of, go up against the urologist and really have it out and have some fun, and we do, and we try to get everyone kind of riled up. But one of my slides is, radiation's advantage is if the cancer's going past the prostate, we're gonna get it. If it's going past the prostate and we just lift the prostate out, we didn't get it, and it can grow back. Of course, if there's lymph nodes involved, at radiation we can go and treat those. We can sterilize the lymph nodes. And if there's a node which is positive, we have techniques that allow us to dose escalate. That's just sort of what that green is kind of representing. Also, too, we're finding that many of the surgeons, they want good sexual outcomes. So they're trying to do what's called nerve-sparing prostatectomies, which is fine for low-risk cancer when the cancer is confined into the prostate. But the problem is the neurovascular bundles, the things that we're trying to spare, the nerves which are going into the prostate, those are paths, those are highways for cancer to escape from the prostate. So if we go spare it, so we hope the guy will have good erections, well, if this PSA comes back, then we're going to take away your testosterone, and God help you to try to get an erection. So you can see how this gets very, very convoluted. With radiation, we treat all of that. We also know dose escalation is meaningful. There's a bunch of randomized trials where we did low doses of radiation, high doses of radiation. The more radiation we can give, the higher probability of curing the cancer or having biochemical freedom. Basically, PSA goes down and stays down. And there's been some analysis that every 2 gray that we can get past 70 gray, we can decrease death by 8% in the intermediate risk prostate cancer population. Now, currently we give about 80 gray of radiation. We might be able to give more radiation in the future or use bigger fractionations of radiation, especially now that these gels exist, so we can protect the rectum a bit better. So unfavorable risk cancer. Well, the thing here, which I think is important, is, guys can go to surgery. We understand that some will. But those who are getting radiation, if they can tolerate, and sometimes we have to be very judicious on who we give things to, but a brachytherapy boost is part of the radiation strategy. Now, I'm looking at some of my patients in this room. We didn't use this strategy, but there was a method to our madness, I promise you. But there's data which I want to show you. High risk situations, very high risk, we treat the pelvic lymph nodes. We give 2 years of hormonal therapy. We take away your testosterone because that's the food source for the prostate cancer. Think about trying to starve the cancer. We can get up, we can kill it. It all has apoptosis, dies. Very high risk, we're treating the pelvic lymph nodes with a brachytherapy boost and hormonal therapy. High risk, we're treating the prostate seminal vesicles, brachytherapy boost and hormonal therapy. And this is the intermediate risk category slide from Peter Grimm. Interesting, because now when you look at the blues and purples, and you want to be high up, you want freedom from biochemical control. When you sequence PSA or brachytherapy boost, your PSA goes low and stays low, much more than with surgery or radiation by itself. And in the high-risk settings, it becomes very telling, where now the curves really separate. We know surgery is probably not the best thing to do in these settings. Although nationally, more guys with high-risk cancer are going to surgery because we stopped screening. We don't have as many low-risk patients to treat. A lot of the patients we have to treat are intermediate and high risk. Everyone has a business to run. High-risk guys are going to surgery. Should, in my opinion. Some people would argue it's the ultimate local control. But if you get that, then you have to have radiation to go clean up what was left behind. You're getting toxicity from both treatments, the double whammy. So this is, I think, interesting. This is the top institutions in the country. It's been published about 10 years ago, so it's getting a little dated, but they basically use they use biopsy data to determine how people did. And I just want to show you a Gleason score, 8 and above disease, there's a 35% chance of dying of prostate cancer if treated inappropriately. That's high. When you look at just PSA survival, meaning the PSA goes down low and stays low, when you have greater than Gleason 8 disease, when you go to surgery, the chances at 7 to 9 years of it staying low are between 30 and 40%. So that means 60 to 70% of guys are going to have to deal with the PSA recurrence. Pretty high. So I want to show this randomized trial. This is interesting, and this is why we shaped our pathways at the Farber and Brigham as we did, because men were randomized to pelvic radiation and then a cone down of radiation to the prostate and seminal vesicles with a year of hormonal therapy, or that pelvic radiation year of hormonal therapy with a brachytherapy boost. So you're comparing basically extreme beam radiation therapy with hormones to external beam radiation therapy hormones plus the brachytherapy boost to give you that ultimate dose escalation. And what we see is in the intermediate risk population at 7 to 9 years, it's a 13 to 24% improvement. If that was a drug, that stock would be worth billions of dollars, essentially. Same thing in the high-risk population, actually a little more telling, that at 7 to 9 years, we're getting almost a 20% increase in control by sequencing those PSAs. But that's assuming that we're gonna live another 15, 20 years. And so sometimes if we're looking at life expectancies and things like that, when we do this, it's a little more toxic. I've done something to you for a few months after we do brachytherapy. So it's not always appropriate, but it's appropriate, many times. And if you use the PSA threshold of 0.2, which the surgeons use, then those curves really separate. Because we know if your PSA goes to less than 0.2 at radiation, chances of this coming back is very, very, very low. And again, obviously dose escalation means something, and dose escalation using the radiation seeds. So just to put this in comparison, if we look at the surgical data in the high-risk setting, biochemical progression-free survival, 30 to 40%, compared to 82%. That's double. Double. That's the data. No overall survival difference yet. Now, this trial wasn't published, so the detractors will say, well, with just the PSA, we'll do something, we'll salvage you, you're gonna live, we'll keep you on this earth, we're gonna give you salvage therapies. But, those salvage therapies can be pretty toxic and they're very expensive to society. However, we start to see that there might be overall survival benefits. This is Dr. Pickle's group out of Canada. And he's basically looking at PSA survival in healthy young guys who get more than 10 years left in the gas tanks. And those curves start to separate. If you have PSA control versus not, guys with PSA control are living longer. So it's manifesting into a survival benefit. Folks from, this one is from UCLA and Fox Chase, they pooled their data. They looked at 1,800 men, high-risk disease, 9 and 10. They looked at radical prostatectomy, external beam radiation therapy, or external beam radiation therapy and the prostate brachytherapy boost. 10-year prostate cancer specific mortality, meaning I died of my prostate cancer. 23% with surgery, 24% with external beam radiation therapy, so same, but decreased to 12% or half if they put the radiation seeds in as well. Failure from salvage, you can see all this stuff, but just having to have hormonal therapy or systemic salvage, chemotherapy, hormones, 5% if we use brachytherapy versus 24% if we used surgery or 12% if we used external beam. And then we started to look at stuff. This is Paul Whitney and one of my colleagues in town. They looked at this Sears database, again, a huge database of patients, 50,000 patients. 20% had a prostate brachytherapy boost. They matched everything for the folks who were being the Ascend trial. And essentially, a hazard ratio of dying of prostate cancer was decreased by 30%. You had 30% higher probability of living if we had a prostate brachytherapy boost sequenced in. So in 2017, May, the Journal of Clinical Oncology, one of our premier journals, the American Society of Clinical Oncology, the Canadians, they came together and they made a joint statement for the first time, which is pretty interesting. Intermediate risk prostate cancer, with or without androgen deprivation, but should be offered a brachytherapy boost. High risk patients with androgen deprivation therapy, if you're getting external beam, should be offered a brachytherapy boost. And our guidelines, reflect this. So we just take the last few moments and talk about brachytherapy. Now, not everybody qualifies. I see a lot of individuals from all over the place, and they come in and say, Doc, I want brachytherapy. And I say, that's wonderful, but I can't do it. Why? Because it's not for everybody. There is some toxicities associated with it. There's some geometry issues that make it difficult. If you have a lot of grief with your prostate, if you're peeing every hour, you're getting up 6 times per night, and that prostate's obstructing your bladder, well, you probably don't want that prostate. It's causing you lots of trouble. If I put radiation seeds in, I'm going to cause a lot of swelling, and you might have to have a catheter for a while. Now, we can do urine dynamics. There's different things we can do, some medical interventions. We can try to, kind of buff you up to get you there, but not everybody. If you had prior radiation to the pelvis, rectal cancers, things like that, it's a contraindication. We don't shy away from this in my group because we do a lot of salvage and things like that. We put spacers in, we can do it. But for the general population, no. And I run, I'm part of the American Brachytherapy Society, so we write some of these guidelines. And so we want to be careful that we just don't open the floodgates and let everyone do different things. We've got to be careful. You've got to be very thoughtful and have a program to support doing some of this stuff. If you had a TURP, a little roto-rooter procedure so you can pee better, if it's small, okay, we can get around it. If it's too big, no place to put the seeds. Median lobes, they look like Mickey Mouse ears coming off the prostate. Might have to cut those off before we do brachy. The gland is too big or too small, it's difficult. We don't discriminate on size in our practice because we have a pretty robust program, but some do if you have inflammatory bowel disease. There are contraindications though. If you have a limited life expectancy, why go to the operating room and take the risk of anesthesia? Well, what if you can't tolerate anesthesia? Distant metastasis, cancer, cat's out of the bag. The cat's, it's cancer someplace else. So treating the prostate, we can do it in a more gentle way. Big TRP deficits, genetic disorders that make you more susceptible to secondary cancers with any radiation exposure. Or if you don't have a rectum, you had an anal cancer and they had to take away the anus or rectum, so there's no place to put the probe. We do this MR directed, so we've made a relative contraindication, but it's something to pay attention to. That's Peter Grimm. This slide is from my residency many years ago. Again, he was one of the fathers of prostate brachytherapy, and I do pay homage to him because it was really his ability to get the word out that has offered this to so many men and so many people. So this is what it looks like over at Milford when we do this. I'm the tall, goofy-looking guy right there. The urologist is right next to me. My physicist, because this is all math. This is all math and physics when we do this. It's all math and physics. Radiation oncologist, we board in clinical medicine. We also have to board in physics, and we have to board in biology. He's helping run these computers. What we're doing is we're doing 500 iterations, 500 unique plans for the patient in the operating room real time. It takes about 90 seconds to run all those plans so we can pick the best solution. We're going to link the seeds together because when we put the seeds in, they can be in an infinite arrangement. It could be anything. The supercomputers can pretty much figure out anything. But the gentleman over at this table is building my seed train so I can put the right combination. And Helen, right there, is actually right there, quality control, because we want to make sure that everything that was built is built correctly. Second set of eyes. Measure twice, cut once. We use the Quick Link system. It allows us to create any infinite combination of seeds. It actually works out very well. We link our seeds together so I can put them on the capsule so I can get past the prostate, so I can get that kill zone farther past the prostate. I can also pull the seeds out laterally so I can spare the urethra. That's what it looks like when we link them together. This is another absorbable material that will dissolve over time, leaves the seeds behind. So when we put things in the body, we want them to dissolve and go away. The things that do stay behind are the titanium encapsulated seeds. Titanium, we make artificial hips and knees out of it. The body doesn't react against it. Everything else would melt away. We also can implant the seminal vesicles. So we know the seminal vesicles, if you have disease up by the base, the seminal vesicles are little tubes that make fluid as well, which are at the top of the prostate. We implant those. We implant the proximal centimeter because the data suggests that the probability of the cancer past a centimeter is very low. But we have the ability to implant the seminal vesicles because we link our seeds together. If you don't link your seeds together and you have an orgasm, those can all go shooting out when you have an orgasm. But if you link them together, they stay in place. So we feel that we can treat this well, and we do check to make sure they stay in place. We also know that dose escalation, I've been showing you all this stuff, the more dose we can give, the better off we are. But we also have an understanding that if a cancer is going to come back, it's going to come back at the area of the dominant nodule, where you started on MRI. So we're dose escalating these areas. We give more radiation dose to these areas, and we can do that by putting seeds back to back. We have the MRIs. We know where everything is supposed to go. We can give extra dose to have a higher probability of control. And dose gradients. Again, I alluded to this before, but the radiation fall off of with isotopes or seeds, when we put them directly in the prostate, the dose falls off quickly. So you can get very high doses to the prostate, but the dose to the surrounding tissue is less because there's less dose that penetrates. It's not coming from the outside in. It's all locally put in. And my dose, if I can do everything correctly, will fall off before it hits the structures I'm concerned about, the urethra, the rectum, the bladder. We did something called the HELP technique to emulate high dose rate. High dose rate radiations, where we put catheters in, we put a source in, take the source out, we do multiple insertions. It's a little cumbersome. This we can do in an hour, and we're good to go. But we also know there was a little bit of dose painting you can do. I can give a little more dose here, a little more dose there with high dose rate. And we do high dose rate at times when we need to. But we put a system together, we can emulate all of that by using the supercomputers and everything else, inverse planning. So basically we know that we can make something that looks like this. Give green, curative dose to the entire prostate. My red, that's the peripheral zone. That's what cancer is 95% of the time. When I have a blind biopsy, even MRIs, I know there's still a probability of this cancer elsewhere that I don't know about on that map that I was given. So, but I know it's probably in the peripheral zone. So I give that 150% of my radiation dose. The dominant nodules, the areas we know if the cancer is going to recur, I give 200% of the radiation dose. And we can dose paint so we can provide the radiation where it needs to go. And we keep it off the rectum, and we keep it off the bladder, and we keep it off the urethra. So one of the questions I get all the time, and we're almost finished. I see my Kate, who is in charge of keeping me on time, looking at a watch. Basically, well, I'm radioactive, aren't I, Doc? What am I going to do? And this is a shared decision making, and I love the fact that I see a lot of men and women in the audience. You brought your spouses and partners with you. What am I going to do to my wife? Well, there's one of those things where everyone has that, oh, I wish I did that study moment. Well, this study, they put radiation detectors everywhere on the patient, the patient's wife, the kids, the family dog, the walls, everywhere. And the radiation exposure to the wife, assuming you're sleeping in the same bed and having sexual intercourse, the whole deal, was 0.1 millisieverts. If I fly from Boston to San Francisco, I get 0.12. So if I come back, I get twice the radiation exposure. So very safe. We just say don't put kids in your lap for the first month, but really very safe, very little radiation. The half value layer is 5 centimeters of tissue, basically. We all have 5 centimeters of tissue, no matter how skinny we are. Is brachytherapy good for young patients? I implant people in their late 40s, basically my age. I have guys who come and see me, and I will put radiation seeds in. Urologists will sometimes say, well, they're so young, you can't do that. We should just take it out. And I say, why do I want them, especially at this age, and to have troubles with erectile function and all the other things that go along with it, incontinence. So I do implant them. But Merrick and Potter, two very prominent brachytherapists, have put series together. Okay, well, if we do this for patients less than 60. All right, 60, that works pretty well. 54, 54 works pretty well. Let's do 50. And then when you get to less than 50, there's so few cancers being diagnosed, it's hard to go any lower. But we know this works, we know it's durable. But the question becomes, and what gets thrown at you is, well, geez, you're using radiation. You're going to cause a secondary cancer in 30, 40 years. And I talk to urologists all the time, and this happens. It's like, oh, someone did seeds way back then. They have this bladder cancer. I'm like, well, the bladder cancer is way up there, and there was no radiation exposure, so it's probably impossible, but I guess we'll take the blame. So they did look at 235,000 patients in these database studies, and essentially, if you rule out, you have to have a second cancer after 5 years, because before 5 years, it's probably just because we screen you. You're now in the oncologist's care. There's a gentleman in this room where, he came to see an oncologist, and I said, what'd you do in your life? Well, I did this and that. I'm like, we're getting a chest x-ray. And we found another cancer, which is probably going to be a hell of a lot more problematic than a prostate cancer taken care of. I diagnose a bunch of rectal cancers every year, which would probably be a hell of a lot more problematic. We take care of them. If I turn a blind eye to that whole thing and I put radiation seeds in or give any kind of radiation, you cause a secondary cancer. No, it was there. No one looked for it. So we look for it. And so this study is interesting. There doesn't seem to be any excess risk of secondary cancers with brachytherapy. Maybe slightly more with external beam because we do have to go from the outside in and more tissue is being seen, but not with brachytherapy. So last 2 slides. I do a lot of stuff with the government where we do kind of this comparative analysis, but also reimbursements. Brachytherapy is not paid as well as it used to be. So therefore it's falling off to some degree because we get, some people want to do what they get paid for. So we do show a lot of this comparative analysis. Basically what this slide is showing is your quality of life between active surveillance and brachytherapy is essentially the same. It's more expensive to do active surveillance because we've got to do more biopsies and more PSAs and more follow-up. Your quality of life is actually very good with brachytherapy. It's actually just as good as if you get IMRT, which is a very gentle approach of treating prostate cancer, but brachytherapy is relatively cheap. IMRT is relatively expensive. And when you look at prostatectomy, it starts to show poor quality of life, and it's more expensive. So when you're trying to do comparative analysis, you have to look at all of this stuff. You hate to put money into it, but the fact remains that they were telling us not to screen for PSA because we didn't want to diagnose men with prostate cancer to save money. So we better be financially responsible so that doesn't happen again. And so that's what we're trying to do. And I've worked with some folks at MD Anderson. And what we're trying to do is put these radar charts together, because it gets confusing. You come and talk with me and say, what should I do? Well, I say, well, what's important to you? The value in medicine is patient outcomes over the cost to achieve those outcomes. Well, your cost might be, I don't want to be incontinent. Well, I don't want to lose my erectile function. Well, I want to live at all costs. Everyone's cost is different. Everyone's importance is different. Well, imagine if I can present you these charts that basically say your overall survival is this, your cost is that, and these are your toxicities. We start to do that with IMRT, brachytherapy, and surgery. And not to belabor the point, but when you look at brachytherapy in red, best sexual function, IMRT, second best, prostatectomy is the worst. Bowel function, well, best with surgery and brachy, not as good with IMRT. Of course, we now have that gel. You look at the cost, brachytherapy is very inexpensive, so maybe that's a financially responsible way to go about treating patients. With that, I'm going to stop and take questions. Yeah, so the question was, if you have radiation seeds, could you have radiation afterwards? So the answer is yes and no, in the sense that we do use seeds in combination with radiation all the time, because it's a way of dose escalating. But say you had seeds in the past, and there was it's a 5% chance of failure, and the cancer came back. Could you give radiation and do it uniquely? You can, or you can do another implant with high dose rate catheters with more radiation seeds the year of recurrence. As long as you're cognizant of all the normal tissues around it, understand the dose that you gave, as long as you can stay within those metrics, you can give more if need be. But you have to be very careful on how you do it. And that's where some of the complexity gets to the point that you really want to go to a high volume center of excellence center to have something like that done. Yeah, so the question is, are we using the MRI to fuse with the ultrasound? And actually the urologists who practice within the Milford area Tri-County, which is now the Milford Regional Medical Center doctors, actually have embraced it. And they're offering their patients that fusion biopsy in the OR. I think it's the way to go. I mean, quite honestly, it's one of those things, before this became prime time, we had all the data, the folks in the know were getting an MRI first to really guide their biopsy instead of going blind. So I think there's a lot to it. And I think it's showing that we're getting less clinically insignificant cancers, and we're actually getting the stuff that deserve treatment. Because what happens is if you get diagnosed with a low-risk cancer, you feel obligated to do something. Well, it's always in your mind. So if you can really hone it down to finding the cancers that deserve treatment, everyone's better off. Peace of mind, and of course, just overall survival.
Is there a difference between a prostate MRI and what that gentleman just mentioned?
Yeah, so basically, prostate MRIs have evolved. So we have magnet strength. It's called Tesla. So it's how strong the magnet is. And there's different ways of sequencing it. And really, a multi-parametric MRI basically has to do something more than just looking at the anatomy. They have to look at diffusion-weighted images, contrast enhancement. If they can do that, then they can really hone in what may be a malignancy or not, and then apply that scale of 1 to 5. 1, don't worry about it, to 5, this gentleman has something, go look for it. So in the past, with the lower strength magnets, they would put a coil into the rectum so they could get a better image of the prostate. Now with the higher Tesla magnets, they're migrating away from using the coils.
So if they don't use the coil, chances are it's
probably the higher energy or higher magnet, higher strength magnet. And that's why I think folks are migrating to, because there's a little bit of discomfort when they had to put the coil in. Vietnam era. Obviously we lost a lot of young servicemen, 18 to 26 in that war. And they were doing autopsies on folks, and they were finding prostate cancer in gentlemen that young. Now, it was never going to be clinically significant, probably for another 20, 30, 40, or 50 years. So, it's one of those things, you kind of got unlucky by an examination, which was probably a false positive. Because now you have prostate cancer. By your PSA, you would not have. And you could have lived for the next 5, 10, 15 years before anything would have been changed to the point that said, hey, we probably should do something. Now, the fact remains this is now in your mind, and there's no way to erase that. But as long as active surveillance is just that. It's actively surveilling you. It's not watchful waiting. Come back when you have pain in the bone, so prostate cancer went there. It's staying on top of it and offering you treatments when you need it. Think about it like this. Push those side effects as you're going to get something. No matter what you get, there's going to be some kind of hit to erectile function. There's going to be some kind of hit to something. Push that as far into the future as you can. It's easy to say don't worry about it because I know it's impossible. But you're fortunate to catch something so early that doesn't need treatment. But you're unfortunate that now you know you have something that's going to be having to be dealt with probably in your lifetime because you're so young. But hopefully it's when you're 75, 80, and hopefully we've developed a better way of treating cancer by then. No, it's interesting. I've done, I mean, close to 1,000 of these things. I've only had one patient detained recently, and it was in China, in Beijing. There are radiation detectors within airports. There's a lot of security we don't understand and we don't see, and it's purposeful, so we don't panic. But they did detect the fact that he had some radiation dose. I mean, it was so minuscule. You're trying to figure out how they did, but we give patients cards so they know that the implant was performed. I've had actually a patient picked up at the Pilgrim nuclear power plant because as you're exiting, you have to get pushed up against screens of glass to make sure there's no fallout on you. And they can detect a little bit of surface dose with those machines. Because if we know the cancer is going past the prostate into the seminal vesicles or extracapsular. So, prostatectomy, when it's confined to the prostate, it's great. But it's really not an oncologic operation. To put things in perspective, if we do a breast cancer surgery, so there's a lot of women in this room, they take out the tumor, and they take out 1 centimeter or more of tissue all around it, because you can, it's fat. If you have colon cancer, you take out the cancer in the colon, and you take 5 centimeters on either side, cut it out, and sew it all back together. With a prostatectomy, it's not a true oncologic operation because you can only lift the prostate out. You really can't go scoop the tissue around it because there's nerves and veins and you bleed to death. So if you leave something behind that starts to grow back, well, then we're going to have to give you salvage radiation. Half the guys I treat in a given time have had prostatectomies previously. If there's cancer in the lymph node and they do a sampling, well, we've got to treat those lymph nodes. And we have to use systemic therapies as well. So you've had a lot of therapy. Maybe it's peace of mind and some guys just want to go to surgery and we're not going to stop them because that's, it's a choice. You never wrestle someone and say, do this. Because if they have a bad outcome, they're going to say, shouldn't have done that. You can go do something and have a bad outcome, but if it was your choice, you're like, well, hey, it was my choice. It's just the way it was. But if it's past the prostate, if it's in the lymph nodes, no, I don't recommend the prostatectomy because we're not curing you. We have to give you all these additional therapies to have a chance of curing you. And you get a double whammy because you're getting side effects from surgery and you're going to get side effects from radiation and hormonal therapy. And chemotherapy. In fact, it's funny, I was just in South Africa last year giving a lecture, and it was this tour we started in Johannesburg, went to Durban, and then to Cape Town, and it was basically the urologist, and one of them said, hey, will you stop putting size criteria on these treatment guidelines? Because the insurance companies don't want to pay for it if the prostate's more than 60 cc's. The reason why we say that, it's something you have to pay attention to because when you're putting needles in, you're not going through the rectum, you're going through the perineum, the little piece, that patch of skin between the anus and the testicles, the perineum. The needle goes in, but your hip bone can be in the way. So if your prostate's too big, the bone can block your needle. Now, there's different ways to shrink your prostate or put you in different positions, and we can do MRIs. We know all that stuff. So we use 60 just as, hey, docs, pay attention. But, we implant 75, 80. As long as you have the space and there's not that many symptoms, you can. It's a relative contraindication. And it's something that we probably should change. In fact, it was eye-opening when I was overseas. I'm like, ooh, maybe we should because we're preventing guys from getting this who probably could.
What about chronic conditions like diabetes?
Well, that all weighs into life expectancy. So the one thing that I didn't talk too much on this thing, everything that we do is also based upon how many years we have left in the tank. So we're mortal creatures, and our job as a physician is to take something off which could lead to your mortality. Now, if you have a bunch of competing risks with diabetes, which is uncontrolled, and cardiac disease, and you've had major MIs, and you're 79 or 80, and life expectancy was 76, well, 10 years is probably not something that's going to happen. So we're starting to shy away from dose intensification or treatment intensification because sometimes we only need to get 5 years of control because we're going to die of something else and we don't have to cause all the toxicities of doing it, or that we have to go to surgery. And it's like, geez, I don't want to put this gentleman on the anesthesia because this prostate cancer is not going to kill him. The anesthesia might. And so you have to kind of weigh all that stuff in. And that's why it's always a conversation of, I'm not statistics, I'm not one of 100 guys. Let's personalize this to me and figure what's the best for me. And those are the conversations you have to have with your doc. It's not being selfish. It's like, I understand all the statistics, that's wonderful, but what about me? So the question was, once the cancer gets into the lymph nodes, what do we do? And what happens after that? And essentially, lymph nodes are basically designed to catch any foreign cell, viruses, bacteria, cancer. And prostate cancer typically does read the textbooks. It's kind of this natural progression where it usually goes to the lymph nodes before it gets out to the bones. There's actually been the Stampede trial where they actually looked at guys who had lymph node involved in the pelvis, not all over the body, but in the pelvis. And they were either randomized to gain just hormonal therapy or hormonal therapy and radiation. The ones who get radiation hormonal therapy did much better. There was a time when I was in my training, and I was in Seattle, late 90s and early 2000s, where they would do, before they would do a prostatectomy, they would do a lymph node sampling. And if the lymph node was positive, they would just sew the guy back up and say, we're not taking the prostate, we're done. Nothing we can do here, sorry. Now, obviously, over the past 20 years, a lot of stuff has evolved. But if it's all caught up into a reasonable radiation field, you can treat it. And there's, I didn't talk too much about it, but there's these new Oxman scans and these new PET scans, which are actually sensitive to prostate cancer. So we can now start to look for lymph nodes of the body and treat accordingly. It's been approved in the post-prostatectomy setting, not in the primary treatment setting. This PSMA scans, there's a whole bunch of stuff on the horizon which is coming, which I think is going to allow us to see the whole body. Because the standard PET scan that most people are familiar with is horrible. This FDG PET is horrible for prostate cancer. But these F18 scans, these PSMA scans are probably going to be the wave of the future. So we can actually identify if there's cancer past or someplace else in the body. Another slide set that I didn't show is oligometastatic disease. That basically means cancer which is metastasized outside the prostate elsewhere in the body. If you have less than 5 metastatic deposits in the body, we're starting to be inclined to treat the prostate and some of those metastatic deposits because we know you can do very well because prostate cancer is so slow growing. If more than 5, well, that's the body's becoming overwhelmed. But less than 5, we're going after it, and that's part of our pathway. So, we see people from very low risk, we do nothing, or active surveillance and pay attention, to folks who are metastatic, and most folks would say, well, there's nothing we can do, but there's a lot of things that can actually be done. You just have to have access to them. Yeah, so I took the slide out, but basically brachytherapy fits anywhere. So low risk, very low risk, favorable intermediate risk. We could just do it all by itself, nothing more. When we move to the unfavorable intermediate risk and the high risk, we stack it, we intensify it with external beam radiation. Because usually in that setting, I want to treat your pelvic lymph nodes as well to sterilize anything in the pelvis, or treat way past where I might be able to get the radiation seed dose. So, brachytherapy can fit actually in every, I do the selection, where's brachytherapy fit in, and the punchline at the end is everywhere. But it's not always the best just to have that by itself. Sometimes we have to use hormonal therapy and external beam radiation as well. But low risk and favorable intermediate risk, you can do it by itself.
When you consider high risk, you consider 8 or above, correct?
Right. Or some of the unfavorable intermediates like the 4+7 Gleason score with PSA greater than 15, with more than 50% of the core is positive. That's to get our attention. We put you more on the high-risk strategy, with treatment strategies. Well, it's always a question. There's a handful of guys I do implant every year with that 4+3, kind of on that unfavorable intermediate where you're saying to yourself, no, we should probably just stack all these treatments together. And the guy's like, no, I'm not going to do it. I'll do this. And you get the MRIs, you get every imaging that all the imaging that we can get, and you don't see anything else. And you say, well, this isn't what we consider standard, but we can treat you off pathway. We try to stay with the data, though, and the data suggests for the more unfavorable folks that more, it's not Texas, more is not always better, but there are situations where we know that we need more of a systemic effect with manipulation of hormones and things like that to get our best chance, because there's always that risk of micrometastatic disease outside of the prostate. Yeah, so the question, what's hormonal therapy? So basically, it's just a fancy way. It's called androgen deprivation therapy, but it's a fancy way of saying that we want to shut off the production of testosterone. Testosterone is the male sex hormone. That's the stuff that coursed through, our system when we hit puberty. Been living with it since. It makes, sort of men aggressive, helps us with our erections, muscle mass, things like that. However, there's almost no cancer that starts off not sensitive to testosterone. In fact, kids who get in accidents and lose their testicles, and that's where 95% of testosterone is made in the testicles, typically don't develop prostate cancer. The eunuchs of old didn't develop prostate cancer. So prostate, the reason why most men will get prostate cancer at some time in their life expectancy, and the older we get, the higher the probability of getting prostate cancer, is all that continuous exposure to testosterone. It's the food. So androgen deprivation is just a fancy way of saying we give you a shot, trick your body into thinking you're making too much testosterone, so you shut off production. And then we try to starve the cancer cells accordingly. Typically we have the MRIs reviewed. We just get the scans and we have our radiologist take a peek at it versus getting a new one. If you're coming from an outside system, we do by default have to have the pathology reviewed. So if you come into the Brigham Dana-Farber system, the Milford is part of the system. But if it's pathology from like Greater Boston Urology, things like that, we do have to have it reviewed. It's hospital policy, by the CEOs of the hospital. And so that's the only thing, but it's not another biopsy. It's just other sets of eyes. Typically we don't recommend them more than once a year. There's some data, the more biopsies we have, that can lead to erectile dysfunction as well. 5 may be the magic number, we don't know. It hasn't been published. We've got to be careful. So it's not one that you want every 5 years. If everything, you want one within the first year, but then maybe you push off the next one 2 or 3 years. 2 or 3 years. Try to get as much mileage out of those as possible. But if you're on active surveillance protocol and your PSA was 6 last week and it turned to 18 and there was no discernible cause like prostatitis, you bought yourself another biopsy within that 1 year window. Yeah, no, it is. So PSA velocity becomes PSA doubling time becomes prognostic after sort of prostatectomy, then salvage prostatic phosphoradiation, as it sounds like you had. That's the thing. So early intervention with radiation after surgery is better. I didn't show any of those. I mean, just because I could be up here and talk for hours and hours, and I know, folks want to go home. But there's studies that show that if you don't interact early enough, if you wait until the PSA gets to 1 or above, and it's like a 20% chance that the salvage radiation is going to work. If you can get it before it hits 0.02, like the 0.01 range, it's about an 80% chance it's going to work. So time is of the essence, but it's never 100%. So right now, I think what's the better part of valor is to try to figure out, well, something's making the PSA. Where is it? Because if you find, and we're doing this now, and this is kind of a little bit of a gray zone, we're still trying to figure out how to do this in the country. And I just saw a gentleman today who, 42, when he was diagnosed with prostate cancer, had a radical prostatectomy, horrific disease all over the place, already metastatic, but he was 42, let's just take it out. I gave him salvage radiation. He had a local recurrence in the prostatic fossa. I mean, obviously aggressive cancer came back. That's gone. It went to his L spine. We gave him very special SBRT radiation to the L spine. That's gone. He came back today because he got one of those special scans, the Oxman scans, and basically has a confluence of lymph nodes, which was never treated. That's his only set of disease. So I'm going to treat him. And maybe that's it. Maybe we'll get lucky. Maybe there's more elsewhere, but we can definitely debulk. And this is where, things are kind of, the data is not there yet. Maybe we're overtreating. We don't know. We're going to do all the studies to figure it out. But if you can just define one place in your body where the cancer is and it's set up shop and it's, kind of growing, why not just eradicate it? And that's sort of our current thinking. And, we might do this again in 6 months and we have a different thinking process, but currently that's our thinking. So I would definitely do it. Find out where it is. And if you can do something about it, do something about it.
So PET scan should show up.
Yeah, as long as you're getting the right one, as long as you're getting the right one. I keep walking out of the camera here, but as long as, if you're getting the F18 scan, the F18, yeah, the Oxman. Not that you don't want an FDG PET scan. You don't want an FDG PET scan. I'm sure if they ordered it, it's the right one. See, Medicare is paying for it, so you have to be over 65. You have to be on Medicare, and you've had a prostatectomy. I think you've hit all 3 of those. So I'm sure you're getting the right one. But if not, ask. You can always call me and I can tell you. Ask. Okay. I know it's late. I'll stick around if anybody has any other questions. But thank you all for attending tonight.
Thank you.